there? Is it working?
Does it come out of this?
Yes, it does. Just pull up.
Pull up. Am I strong enough? Yeah. There you go.
Okay, how's that? I pace. I hate a podium.
Okay.
So ignore me pacing.
All right, give me a second. Where'd my mouse go? There it is.
I have so many things to hold. All right. So, hey everybody, I'm Sarah King. So I am from Fort Wayne, Indiana. So I don't know if anyone is familiar. But anyway, it's the second largest city in Indiana. And by training,
Indiana or Purdue? Who do you like?
I'm an IU person.
All right, then I'll stay.
Okay, there we go. I'm waiting for someone to get up and walk out now. So I went to IU for undergrad, so that's
I
where
grew up in Indiana.
Very nice. Yeah. So by training, I'm a genetic counselor. So for those of you who have genetic testing, or if you've seen a genetic counselor, that is what I've done. I've been a genetic counselor for 11 years now. And now I work for a company called Exact Sciences. So if anyone's had the Oncotype DX test, that is the testing we do. So I was sitting here listening to their stories, and I thought, instead of just jumping into some more medical slides for you guys, I would start with a really embarrassing story that I've sat here and gone back and forth whether to tell you or not. So as a genetic counselor, you get asked a lot of weird questions. So first is like, do you grow babies in jars? Or like, people just ask very weird things. I used to be in high-risk pregnancy, and people had a lot of questions on how you do genetic testing in pregnancy. And then I switched to oncology, and that tends to, lead down one or two rabbit holes. Either people want to talk about ancestry testing. Oh, sorry. This is why I can't. Yeah. People want to talk about ancestry testing. And so I also am really involved in real estate. So I do real estate investing, and I'm at a real estate conference, and I've had at least 4 beers. And I'm with a girl in a hot tub, and a bunch of girls. There's a big group of us. And she's sitting there, and she's like, oh yeah, my dad had breast cancer. And it's interesting how everything touches you. And so that was the first time I'd ever met Katie before, and then I end up in an impromptu genetic counseling session where she ends up being a BRCA2 carrier. So that's a genetic predisposition to hereditary breast cancer. And naturally, I'm trying to play it cool after too many cocktails, and we're sitting there and we do a whole full-on genetics consultation. So that was not my best. She's like, you went from sloughing over a little bit to a full-on clear, coherent speech about how I should be getting breast MRIs. And so it was fairly impressive, but me and Katie ended up being best friends. We still talk, and her dad ended up passing away this year. And so being friends with her she lives in Virginia, I live in Indiana, but we talk at least once a week, and being with her is her whole life changed. So she's a nurse by training, and she ended up quitting her job to take care of her dad in the last 2 years of his life. And so watching such a good friend of yours go through taking care of her dad, and then also I'm keep remembering your own health too, and taking care of yourself. So groups like this are so important, because you guys talk about the male experience, which never gets talked about. And so Katie's it's like talking to a unicorn. I didn't have to explain to you that males have breast cancer. And I'm like, yes, that happens. I've seen a male patient myself and worked with. He was a home builder, and so we had a lot of things to talk about. And so it's interesting. You don't expect it to come up in a hot tub at a real estate conference. So that's my embarrassing story. So yeah, you just never know. Full disclosure, I'm employed by Exact Sciences, so they paid my flight here. All right, so really quick overview. So I think we've come and talked to you guys before. This is the first time I've met all of you guys, but I want to take a little bit different approach, because I think a lot of people have come and talked to you about hereditary cancer testing. So things like BRCA1 and 2. I want to talk about Oncotype and our data in that. And then I want to go over what I think is the future, the cool diagnostic tests coming down the pipeline. So I'll try to keep this somewhat entertaining. Feel free to get snacks or ask questions. All right, so there's 2 ways to look at genetic tests in general. So if you think about them in buckets, you have germline testing, which is essentially egg or sperm. So those are things you're born with. So from day 1 of conception, from, when sperm and egg come together, we know the birds and the bees talk, right? So the germline box on the left is present since birth, and these are things that run in families. So BRCA1 and 2, hereditary cancer testing, so likely testing that a lot of you have been through. What I'm going to be talking about today, though, is somatic testing, or things that are acquired. So as you age, we naturally get genetic changes in our body. So it's a part of the aging process. That's how, when you're 20, you have wrinkle-free skin, and when you're older, I'm cheating with Botox, so it helps. So we all, go through this process, and you can see it on our skin, but you don't think about every cell of your body as having mutations or changes. And so if mutations happen in important genes or important part of our body, things can develop. So I always say, like, cancer is when a good cell goes bad. So if we naturally have breast cancer cells, men and women. I'm now preaching to the choir on that, so you guys know. And so when you have these mutations happening in the body, you can develop cancer. And so a normal breast cell essentially develops and now grows uncontrollably, and we think about that as cancer. All right, so this is, I'm gonna switch sides. Am I out of your thing now? Okay. So this is our cancer care continuum. So I'm in Exact Sciences, and so we offer a full portfolio of tests. So I thought I'd start with just making sure you guys know what all is out there. So whether it's our product, whether it's someone else's product, I just figured we'd just do an overview of kind of where we are with cancer diagnostics today. So on the far left-hand side, I think I'm making it buzz. Sorry, I'll stop pacing. All right. So on the far left-hand side over here, you'll see hereditary cancer. So that's what we just talked about. So your BRCA1 or 2, those can be for people that are asymptomatic or who haven't had breast cancer yet but may have a family history. And so that's when you might start looking at your family tree and think, I haven't had cancer, but maybe I know someone that's been touched by it. As you go on to screening and surveillance, one of the big things our company is known for is Cologuard. So we are notorious for this. Anyone over 45 has likely been offered this. It is essentially you are sent a blue box, and it's a poop in a box option instead of getting a colonoscopy. My husband's joke to anyone that will listen to him is that I store boxes of poop in my basement, and that is what my wife does for a living. So, and I'm like, no, I give presentations for a living. So, but yeah, lots of boxes of poop. So if you know Cologuard, it's a great test. Something really exciting that we're going to have, ideally by the end of the year, we'll see if it happens, but definitely in 2026, is a brand new test called CancerGuard, and this is a liquid biopsy. So this is something, so there are companies out there currently offering a liquid biopsy. So what that is essentially they draw a sample of your blood and can detect whether cancer is present in your body or not. That is without knowing if you've had a prior cancer. That is just screening for average risk individuals or high risk individuals that have not yet had cancer and are wondering, am I developing it? I think somewhere really exciting will be those cancers that get detected really late, like pancreatic cancer, ovarian. If you know you have a strong family history, I think that's where tests like CancerGuard are really going to make a big difference. And so that's coming down the pipeline. In the middle is the test that Brett and I had talked about him having and his mom, and so Oncotype DX is really how people think about, it's kind of a clinical decision-making tool, and we'll talk about that kind of in depth. And then I actually have data of male breast cancer patients specifically, so I can tell you, besides Oncotype just in general treating breast cancer, let's look at how the test performs in men. On the far right-hand side, right for you guys, is our therapy selection test. So this is for advanced stage cancer. So if you have metastatic cancer or it spreads somewhere in the body, sometimes you've done multiple rounds of therapy and you're looking for what's next, what kind of treatment can I do? And they can take a tumor sample and look at what potential genetic changes are there that we can target with personalized medicine. So a little bit what the previous speaker was talking about. And then at the end, I'm going to talk about this middle column where it says Oncodetect, because this is where I think it's a really cool space that I think you guys will be really excited about. And that's called MRD, or molecular residual disease, which I'll explain by the end. But yeah, so we're going to first talk about Oncotype. So who in here has heard of Oncotype DX? Cool, awesome. So I don't have to explain it too much for you guys. Okay, so traditionally when you think about hereditary cancer, so before genetic tests existed, there were only they could look at tumors and really say, based on what we know about the tumor, what can we do to treat it? Many, many years ago, they used a patient's age, maybe if they had any lymph nodes positive, tumor size, tumor grade. Then we started getting additional assays like ERPR and HER2. So how you were talking about, she gets the path report, explains it to a patient, you're all kind of told, what's your ERPR HER2 status, because that really kind of tells you which route you're going to be routed down in terms of treatment and how you'll be followed. Because there's different treatments based on your hormone receptors in the body. So breast cancer is or is not typically driven by hormones. And so what really changed the game is about 20 or 30 years ago, Oncotype came out, so it's been around for a long time. It's really become standard of care. So if you have estrogen, progesterone positive cancer, so hormone-driven cancer, you can do an Oncotype DX test that will tell you whether you would benefit from chemotherapy or not. And so that's a critical decision maker too, because it really kind of helps you make that really hard decision on what treatment you want to have. All right, so you don't need to memorize this at all. It's kind of overwhelming. I tried to put together a different slide for you guys, but ultimately this one made the cut from my medical reviewers. So ignore this, but essentially it's a 21 gene test, and it takes, essentially in the lab, they take your tumor block. So once you've either had a core biopsy or even an excision of the breast cancer, your pathologist in the hospital will take that and send it off for our laboratory testing. They get that sample of tumor and they run it through our testing platform, and we look at levels of gene expression. So every breast cancer expresses genes differently. So some are upregulated, some are downregulated, because cancer is just inherently, like, your cells aren't behaving the way they should be. So it's trying to say what's driving this cancer forward and how sensitive to estrogen is it. All right. So this is an actually Oncotype report, so if any of you have actually seen your report, hopefully you had a good doctor that walked you through what a report looks like when making those decisions. I'm going to zoom in a little bit because I think it'll make it easier. So you will get a score, so an Oncotype score from 0 to 100, and that is going to be on the first tile. The middle tile gives you your 10-year risk of distant recurrence, or 9-year on this report. And so it tells you if you have estrogen therapy or an AI, so like tamoxifen and aromatase inhibitor, what your recurrence risk will my cancer come back, pretty much. And then on the far side over there on tile number 3, it will tell you your lifetime, your benefit of chemotherapy. So can chemotherapy help me? So essentially your really low scores, like your 0 to 25 scores with Oncotype test, are really heavily driven by hormones. So estrogen, progesterone, endocrine therapy treatments like tamoxifen or an AI really help because your cancer is being driven by hormones. And so you're most likely to benefit from a less severe therapy. If you have a score 25 or over in your guy, then that means your cancer is less responsive to those other treatments, and maybe chemotherapy is something you should do in order to prevent that recurrence from happening. Any questions? Okay. Have I confused everyone yet? Are you still with me? I need like an amen. I feel like a pastor. Not a, yeah, go ahead.
So can you explain why? So my cancer was HER2 positive,
Mm-hmm.
and I was not a candidate for Oncotype.
Yeah.
Can you kind of explain why?
Yeah, so if you're HER2 positive, you would benefit from Herceptin. So that's your treatment, and Herceptin is so effective in treating those hormone receptor or the HER2 positive cancers that it really wasn't included in clinical trials, just because you kind of already know the best treatment to treat your cancer. And so deciding chemo versus endocrine therapy, there's just not trials designed for that. And so Herceptin is kind of the main way to go. And then if you have ERPR positivity, then you would still do your endocrine therapy along with that. So kind of your treatment path in like NCCN guidelines is already determined based on hormone receptor or HER2 being positive.
Yes.
All right, so this is new, and so hopefully you guys have probably never seen this before. So there are 2 studies out there that looked at male patients specifically that had Oncotype testing. So first, males were found to have more advanced cancer at diagnosis, so this is what you guys are already talking about, so this is not a surprise to you guys. Most males, so 85%, also had high-grade disease. And you're most likely to actually be a candidate for tests like Oncotype. So you are more likely to be HER2 or ERPR positive and HER2 negative most of the time. So that means most men are actually a candidate for this type of testing. All right, and so the first trial was looking at almost 400,000 patients. But of this, obviously, there's a small male representation, which is pretty normal, obviously, with these studies. So about 3,000 men were included, which I feel like is a pretty impressive number. And about 33% of men had Oncotype DX testing. And women were a little bit more likely to have Oncotype, so about 35%. So again, advocating if you are in this category to make sure you get testing. Characteristics of men is they did tend to be younger at the time they were diagnosed, and they did tend to have more advanced stage disease, so kind of like how all of you have talked about. And I think that's the, is this really happening to me? Did I even know I could have breast cancer? And it's just delaying that diagnosis. And then the good news is similar rates of chemotherapy between men and women, so at least you're more, like if you need chemotherapy, you're getting it, which is positive. All right, this talks about, so this is an older study, so it went to 2014, so I'd be curious to see if they redid this study or, it could be in the works, where it talks about Oncotype uptake in men versus women, and so it seems like historically doctors are less likely to offer Oncotype to guys, but it does look like there's a little uptick, I think, in 2014, so I'm hoping that trend is improving as we've continued educating on Oncotype and the benefits and how there is data in the male population. This is the distribution of scores, and I actually have a better slide coming up. So most men tend to be lower risk. So the blue and the yellow are kind of the under 30 category. So we think of a cutoff of 25 nowadays, and I'll show the updated data. But most men had lower risk tumors, indicating that they could likely just do an endocrine therapy or an aromatase inhibitor versus needing to do chemotherapy. All right, so this is the summary. So again, men are more likely to be estrogen and progesterone receptor positive, and they were more likely to have high proliferation factors and invasion gene scores, which is only interesting to the scientists in our lab, I think. So progressive ER gene expression. So usually we see this in women, and we saw the same thing in men too, where as estrogen gene expression increased with increasing age. So you become more endocrine sensitive the older you get, and you actually respond to the more milder treatment. You're less likely to need chemotherapy. And then they talk about 5-year survival rate. So for men with a recurrent score of under 18, the 5-year breast cancer specific survival, so survival from breast cancer, was 99%. So a low recurrent score is really reassuring. And then 5-year breast cancer specific survival and overall survival, so due to any cause, was lower in men versus women. So with men who had a higher score, so over 31, their breast cancer specific survival was about 81% versus 95% in women. And we think that's probably due to the fact that men just get diagnosed later. They tend to be more advanced, they have high risk disease. So again, advocacy is very important. So you guys are doing good things here. All right, I really liked this chart because it kind of gave a comparison versus men versus women. So men are most likely to have a 0 score, which is really exciting. So very, very low risk, very low likely to recur. And then interestingly, they were either really low or very high. And so those are the ones where we say, you need to do chemotherapy. And so there tend to be a bit more of a spread versus women tend to have a more of a standard distribution of their scores. Put arrows in. Okay. All right, so one thing I did want to note, which is kind of a bummer, I think, from our company, to be honest, speaking as a friend, is when you get a report as a guy, it says it will be a report for a postmenopausal woman. And I feel like that's a huge miss on our part, so I'm just going to be very honest. So when we do these reports, essentially women have, hormones that are very different distribution. Men have testosterone, and so the hormone expression over someone's lifespan is drastically different in men versus women. And so premenopausal women are really high risk because they have so much estrogen in their body to drive and fuel that cancer. It's like giving the cancer food. So after a woman goes through menopause, her levels drop, and then you're at levels similar to a man. So unfortunately for all of you guys, what you get to experience in the doctor's offices, you get a report that says you're a postmenopausal woman. So if you ever see that on your report, that is why. So no matter what age you're diagnosed, you're considered a postmenopausal woman. Just because you don't have that estrogen spike early in life, which is actually a good thing because you tend to have more favorable prognoses when you're a postmenopausal woman. So this goes over the data where it talks about how did we decide the cutoff that we use nowadays on the risk recurrence score. So it's a little bit confusing. So this is 5-year disease-free survival, and on the bottom it's the recurrence score, so 0 to 50 they use as a cutoff. And so if you just look at the solid lines, they found that around the recurrence score of 25, there actually becomes a greater benefit of chemotherapy plus endocrine therapy as compared to just endocrine therapy alone. And so nowadays, for a guy, essentially you can just know the recurrence score of 25 is kind of a magic number. Over 25, we would recommend chemotherapy to reduce risk of cancer. Under 25, you're considered low risk and can just do an endocrine therapy or an aromatase inhibitor. All right, we won't go through that, but essentially this is in a nutshell. So this is again going over postmenopausal women. So this is whether you're node negative or node positive. There is no benefit if you're score 25 or under in patients. So in terms of disease-free survival, there's no benefit of doing the additional chemotherapy. So this is looking at invasive disease-free survival over 10 years. And so essentially you just need to know the purple line and the green line are right on top of each other. There's no separation between the two. So both therapies perform equally if you have a low risk score, 0 to 25. And so that's how we get the numbers and why 25 is kind of the magic number to keep in your mind, and clinicians know that. So that's how you get the reports for Oncotype. And then I want to go into a different test. So I'm going to pivot in a different direction. So that's kind of an overview of the male data and kind of what to expect when you get a report and you're like, why am I postmenopausal? Is a new test called OncoDetect. And I think this is a super cool test. I feel like I was trying to think of an analogy last night where I'm like, I think we're kind of at the future of, medicine right here. In 5 years, everyone will be ordering tests like this. And so, too many things to hold. All right, so this is a test called molecular residual disease, or MRD. And this is a test that looks for molecular, so tiny molecules of DNA, and residual disease, so extra kind of remaining leftover disease. So you would use an MRD test, say you had stage 3 breast cancer. You go to your doctor, you maybe have an Oncotype test, you get that recurrence score, and you decide your treatment path. And say you get an Oncotype score of 0, we know that's really common in guys, and they're like, great, you can just do endocrine therapy and have a surgery, possibly radiation. And so you'll go on, you'll have your surgery, and you'll get to ring the bell and leave the hospital. But a lot of people sit around and wonder, what if? Like, is my cancer still there? Is it going to come back? They gave me my 10-year risk of distant recurrence, but what does that really mean for me? And so what MRD is we take your tissue, that tumor block, so the same block we ran like an Oncotype on, for example, and they develop an assay in the lab that tracks your tumor. And so they build one test based on the tumor, and then they draw blood. So essentially going to a liquid biopsy, but it's personalized for your cancer. So based on your original tumor, they'll now follow variants in your blood over time, and they can tell you if and when your cancer comes back. So instead of going every 6 months or every year and getting an MRI or a PET scan or whatever, imaging modality you're getting, you can do a blood draw. And so it will, it's really interesting. It also gives an early diagnosis. So on average, your cell-free DNA test or your circulating tumor test will come back positive 8 to 10 months, even up to 2 years earlier than it will ever show up on an imaging scan, which is really crazy. Now, the challenge providers are facing with this is we can find your cancer earlier, about a year earlier on average, and tell you with really high certainty, like you're 50 times greater than a person that had a negative test, that your cancer is coming back. Pretty much we know your cancer is back. It's just the very early stages where we can see those first tumor molecules. The hard part is we don't really know today what to do with that, because we know the cancer is back, but we don't know where it is in the body, and there's no guidelines right now saying how to use this test. So it's a little scary for patients and providers to now tell someone who's had cancer, hey, your cancer's back, but we don't know what to do yet, because there's no guidelines saying we start chemotherapy or not. So we see some doctors using the test, and they'll start chemotherapy, maybe like there's new tests called like CDK4/6 inhibitors, and there's new trials. So it just depends, and I think in 5 years we'll know exactly how to use this. But it's kind of the future, and we just need more people to, more data and more collection around this area. But it's pretty awesome that someday we'll just need to do blood draws to kind of screen people and say, yes or no, has your cancer recurred on a molecular level? So, yeah.
Where's Medicare on this test? Even in their approval queue? Or?
Yes, it is in their approval queue. So we just launched this, I think 4 weeks ago. So this is a brand new test for us. One of the other tests been on the market and is currently covered by Medicare for them. We're in the formulary. We need more information answer back from them. So we're in the giving them more information phase, but we hope to have approval by the end of the year. But it is on the list because, for a lot of like colon cancer, for example, there's a little more, we know a little more what to do with it versus in the breast setting. It's just hard to know what to do. And then also it's hard for the physicians because they don't know where it is in the body. We just know it's back. And you can't see it on imaging yet. And so that can be a little troublesome. Yeah.
And this is similar to the other company that is doing the same. I don't necessarily want to say the
Oh
other
yeah,
company,
no,
but-
yeah. Yeah, it's very similar. So there's, I think 4 or 5 companies now that have one of these tests. Some of them are more sensitive than others, and so they can detect, like, for our test, if you have 1 million fragments of DNA, we only need 50 fragments out of 1 million in order to see the cancer. And so, like, the leading person in the market today needs to see 100 fragments of tumor before they can call, like, the answer and say, yes, we think your cancer is back. And so ours is a bit more sensitive. But there's other companies on the market right now that aren't as used that need, like, 1 fragment out of 1 million, which is crazy. So, like, it's kind of like we see the future with those tests. And I think that's eventually where we'll go is it's kind of a race for who can detect the smallest tumor most confidently. So.
But then figuring out what to do about it.
Yeah, but then the doctor's like, oh my gosh, this is terrible. Like, they aren't really sure what to do because there's just no guidelines in the space right now. And so we have some doctors that draw it on every patient, and we have some doctors that will call other doctors and yell at them for ordering it, saying, there's no guidelines, stop doing this and sending them to me, because we just don't know what to do and the patients are nervous. But again, the lead time is a benefit. We just have to figure out how to use it, because we know early detection is so important. Yeah.
So if you have more chemotherapy based on this test, would you do another test later to determine if that chemotherapy had wiped out the remaining cancer cells that might be floating around in there?
Yeah, so with Oncotype, it will tell you chemotherapy or not, and then Oncotype isn't a test you repeat because it'll tell you like chemo benefit based on your first tumor biology, and so Oncotype's a one and done test. Then once you've finished your chemotherapy and they believe you're cancer free, then you could do something like an MRD and it can tell you yes or no, is it gone, if we were able to detect it. But yeah, so you kind of need 2 different tests, but the answer is yes, but Oncotype's a one and done kind of thing. Yeah.
So, as I stated earlier, after my first incidence, I had an Oncotype score, I think it was low.
Yeah.
It was like 13, maybe less than that. And it came back.
Mm-hmm.
So my question is, maybe it wasn't the oncotype, and maybe they missed some cells when they did the surgery. But I was an outlier, obviously.
Right.
Yeah. So, was there any testing on what the failure rate of the oncotype
Right.
test is? Like, somebody got a low score, but it came back. Have you done any studies?
Yeah, so we do have concordance data, and it's never like 100%. It's always going to modify your number. So we're never going to say like your cancer has a 0% chance of coming back. We just know the highest odds of it not coming back is if you do endocrine therapy and an aromatase inhibitor, or either or, and surgery. The hard part is it doesn't it's not 100%. It's just a diagnostic test kind of pointing which direction you should go on your path. The hard part is we know it happens. And so there is data saying, you know, people do get low scores and have recurrences. The other hard part is, I think in males, it's like we don't know how testosterone plays in there. So you talked a little bit about your testosterone levels being up. And so we know those really low oncotype scores are really hormonally driven. And so sometimes we do have recurrences. And unfortunately, in a lot of those, it's late stage recurrences where it's happening 5-10 years after diagnosis. And people are kind of shocked by that. And that's the hard part of estrogen positive cancer is it's not a 5-year and yay, we made it. It's a 10 to 12 year thing that can be, you know, present in the body and still recur. And so that's one of the hardest parts about that subset of cancer is it is usually really treatable, but it can come back much later than some other types.
So when you're talking about survival rate, it's really 5 years.
It's 10-year data, but that's still not 100%, and it just depends on score. So I could pull up like a report of 13, and you can look at it if you want to, because and it will give you, you know, your recurrence scores, but or your odds. But again, we're all playing the odds, and that's the hard part.
So one thing I just want to encourage us all with is that this is data
Yeah.
and it is open to error.
Yeah.
And you are a human being and cancer happens, right? But we get through it. And so one of the things that I tell my patients is to flip the cup. So when you're looking at this percentage of recurrence rate, flip the cup. What is your percentage of it not coming back?
Right.
And have a little hope there. Because I feel like sometimes with cancer in particular, we go to the worst scenario first. And if you had COPD or you had diabetes or you had something else, you would see that it is a journey. And when I look at survivors, I'm a survivor. When I look at survivors, I think, hallelujah, I don't have to stand only on the test that was done, but I know what exercise is doing now, immunotherapy. There's so much happening that I love, I mean, I love that. The thing that I'm concerned about, and I'm so thankful for the Medicare question, because the Oncotype is extremely expensive. And for those who have not met your deductible or out of pocket, you can be hit with a really large bill to tell you that this was your percentage. I just wish that there was a little more discussion with physicians as to whether or not patients wanted this done, because in our scheme of things, it's pretty much done as a standard of care, right? I guess one thing that I'm wondering when I see all these tests too, what are you as a counselor, a genetic counselor, being trained to do? Because our doctors do offer the tests, they do go through it, but it's our genetic counselors who really give the bulk of the understanding to patients about screening.
Right.
And are you finding that there are, or is your company doing training for genetic counselors to this end?
So we don't do training for usually genetic counselors come out of training, like we're trained in hereditary cancer testing. So I do education specifically for doctors and physicians. So that's my job. And I have a whole team of people that do the same thing. Hopefully your doctors did informed consent with you before ordering tests, because that's terrifying. That's a huge miss. Because you obviously need to know like everything you get is elective.
Probably signed a form,
Right. Yeah. But it is hard because like in the NCCN guidelines, it's a part of the guidelines that you do that test. Yeah, go ahead.
Yes, sir. I would, you know, again, I just went through this late last year, so I went down the research rabbit hole when I got this.
Yeah.
This score. And I found it, I think it was the National Library of Medicine or something. They did one and they really started breaking out men versus women.
Yeah.
And when you look at that score where, you know, 25 is kind of that cutoff,
Yeah.
this particular study really showed where the recurrence, really the mortality rate of women kind of followed a curve that went like that.
Yeah.
But in the smaller shape of men, once you got to like 2022, it really plateaued out.
Yeah.
Can you talk to, because then for me, sitting at a score of 18, that kind of freaked me out a little bit, right? I'm like, okay, I'm right there at that 20 level where is anybody looking at the score difference in men? Is there enough of a sample patients that we're still kind of in that beginning stage?
We're definitely still in an unknown phase. I will say one of the tools that we brought out for node positive and negative now is a thing called RS Clin that your doctors can run, which is newer. Especially, we just launched node positive this winter, so in December. So if you have a recurrence score, you can actually, because we know recurrence score, this is all data, like it's all scientific research. And so when you are actually looking at the score, you're like, well, I'm a human being and I have a tumor that's this size and a tumor that's this grade. And so I think something like this RS Clin, so what you do is your doctor can go online and essentially put in what your recurrence score was, how big your tumor was. So I'm not talking about a research study, I'm talking about like your information, what if you did tamoxifen or not, and then also like the grade and your age. And it can give you a more personalized risk assessment. So for some people at 18, so usually I think like the gray zone areas where you're like, I'm not super comfortable with where my number is, that's creeping pretty close to that 25. That's the perfect time to use this tool, because if you are a guy and you have a high grade or a large tumor, doing something like that, it might push you towards having greater chemotherapy benefit, and that can kind of guide your conversation with your doctor. That is men and women kind of lumped together in a study though, so unfortunately we don't have male-specific data, but that tool is a bit more personalized and tailored to you. So hopefully that would capture some of the risks the guys in the room are getting with that, you know, more advanced cancer diagnosis. So
As you get more and more male data, are you guys trying, are you progressing to that point where it will be looked at from a male specific standpoint, or are we still just such a small number that?
I honestly do not know that answer. It is above my pay grade, but now I will ask.
And we